Good afternoon, everybody, and good morning to Professor Laurence Klotz, who's delivering the oration from Canada live. And the agenda for this 1 hour program is that initially there would be a welcome address by Professor Neena Khanna, who is the Dean of All India Institute of Medical Sciences. For today, she's also the acting director. Then after that, I'll be introducing the oration as well as the orator. And then there would be the oration, and then there would be the presentation award by Professor Neena Khanna. And then finally, there will be a vote of thanks by Dr. Sanjeev Lalwani, our registrar. So I would request Madam to come on the dais and
Good evening to all of you, and good morning, Dr. Klotz. It's a pleasure to have you over for this very prestigious oration. For years, we've had this oration, and we've had very eminent surgeons who have delivered the oration, and we look forward to it. Thank you.
Thank you, Madam. So now I'll talk about Professor Sarinder Mansingh. Dr. Sarinder Mansingh Memorial Oration was instituted in the memory of late Dr. Sarinder Mansingh, who was the first head of the Department of Urology at All India Institute of Medical Sciences. He was not only the first head of the Department of Urology at All India Institute of Medical Sciences, he is considered as the father figure of urology in India. And he is amongst the very few people who kind of initiated and spread urology all over the country. Professor Mansingh was born in 1928 in the city of Muri, which is now in Pakistan. At that time, it was in India, in the pre-partition India. He did his schooling at Doon School in Dehradun. In the year 1945, he was selected for MBBS in King Edward Medical College at Lahore. But we all know that in the year 1947, there was a partition of India and Lahore went to Pakistan. So following the partition of India in 1947, all the students who were pursuing MBBS course in Lahore, they were distributed to various medical colleges in India. Professor Mansingh got a seat in Stanley Medical College, Madras. The city of Madras has now been renamed as city of Chennai. And from this Stanley Medical College, he graduated as the best graduate. He bagged 4 gold medals and 7 prizes. And after completing his medical schooling, he decided to go to England, and he completed his FRCS in a very quick period of 2 years. In 1955, he returned to India and joined Irvine Hospital. That's another big hospital in the city of Delhi. This hospital is now called as Lok Nayak Jayaprakash Hospital. It is actually, in terms of beds, the largest hospital in the city of Delhi. He was initially a registrar, and then later on he was selected as a junior honorary consultant. And in 1958, he got the job of assistant professor of surgery at All India Institute, and he shifted from Lok Nayak Jayaprakash Hospital to All India Institute in 1958. Then he started the urology clinic at AIIMS, and he got a Rockefeller Foundation fellowship in 1961, which enabled him to train in the field of urology at Johns Hopkins Institute in USA. And later on, he also went to Newcastle upon Tyne for further training in urology. On his return in 1963, he got promoted as associate professor, and he initiated the Department of Urology at All India Institute. In 1965, Professor Sarinder Mansingh was invited as inspector by Madras University to start the first MCH course in India. And from 1965 onwards, we have been having MCH training programs in India. In 1968, the first program in MCH urology was started in Chennai, and the second one was started at All India Institute in 1966. During his tenure, he trained more than 70 postgraduates in urology at AIIMS, and all these 70 people are occupying very prestigious positions all over the country. And in fact, some of them have also retired because they grew to very high positions and then retired. In 1974, he was awarded the Senior Commonwealth Fellowship for 3 months, which enabled him to bring back the latest know-how in urology to India. He was one of the pioneers of urology in India and made an impact as a teacher, clinical researcher, and a progressive urologist. He was elected as President of Urology Society of India in 1976. During his long innings at AIIMS, he made immense contribution to the growth and practice of urology in India. Besides the general urology and TUR, he developed special interest in carcinoma of the urinary bladder. He started the bladder tumor registry in India. He standardized the diagnosis and surgical management of pheochromocytoma. His contribution to the field of pheochromocytoma surgery in India is considered a pioneering work. And he built up the largest series of pheochromocytoma surgery in India at that time. Dr. Mansingh was an examiner to all the universities for MCH in urology in India. He published more than 70 papers and participated in all major urological meetings, including BAUS, AUA, and SIU. He was the first member of SIU from India and was on the editorial committee of British Journal of Urology. He started the Delhi Urology Society as an academic forum, which is now a very vibrant body. He was known as a thorough gentleman, kind-hearted, and always ready to help patients and postgraduate students. He lost his wife in 1992. Despite his personal tragedy, he always remained smiling and helpful. We lost him on 8th October 2006. He had a brief illness starting in July. He had a major surgery in 2006 July, but slowly he deteriorated and he had recurrence, and finally we lost him on 8th of October in 2006. He has left behind a legacy that would be difficult to match, and he'll always be remembered for his contribution in the field of urology in India. The family of Professor Mansingh decided to start an oration in his memory, and which was accepted by All India Institute. And for the last 6 years, we are running this oration. The previous orations have been delivered by Professor S.K. Sharma, who was the chairman, Department of Urology at PGI Chandigarh, and he was also the director of PGI Chandigarh. The second oration was delivered by Professor N.P. Gupta, who was the chairman of Department of Urology at All India Institute. And the third one was delivered by Professor Mahendra Bhandari, who was the chief of urology at Sanjay Gandhi Postgraduate Institute in Lucknow, and also the director of SGPJ Lucknow. Then Professor A.K. Hemal from USA, he delivered the fifth oration, and Professor Pramod Sogani was invited for the sixth oration, but he could not do it because of COVID and multiple other reasons. And Professor Gopal Badlani delivered the oration last year, again online, and this year we are lucky to have Professor Laurence Klotz from Canada to deliver this oration. Regarding Professor Laurence Klotz, he did his undergraduate training from the University of Toronto from 1971 to 1973. He did his medical training from the University of Toronto in 1977. He completed in 1977. Then he did his residency from the University of Toronto, Gailey program in surgery, which he completed in 1983. And from 1983 to 1985, he was a special fellow in uro-oncology and tumor biology at the famous Memorial Sloan Kettering Cancer Center in New York. His affiliations, he is Chief Division of Urology at Sunnybrook in Toronto, Canada. He is Professor, Department of Surgery, University of Toronto. He is former Chair, Canadian Uro-Oncology Group and NCIC GU Site Group. He is Chairman, Global GU Oncology Group. He is Treasurer, Society of Urologic Oncology. He was you can say, the lifetime chairman of the World Uro-Oncology Federation. He started the World Uro-Oncology Federation and he was its founder chairman, and he was the chairman for a very long time. Very recently, he handed over to Dr. Peter Hammerer from Germany. And he is also a member of the American Association of Genitourinary Surgeons. He is President Canadian Urology Association. He was elected honorary member of American Urology Association in the year 2012. He got the Queen's Jubilee Medal in 2013. He got the Society of Urology Oncology Medal in 2014, and he got the Order of Canada in 2015, and he got the Urology Care Foundation Richard Williams Prostate Cancer Research Excellence Award in 2016. So a very honored, decorated person, and we are really lucky to have Professor Laurence Klotz as the orator today. His research foci have been on micronutrients, prostate cancer prevention, and active surveillance. In fact, the concept of active surveillance in prostate cancer was initiated and popularized by Professor Laurence Klotz, and he is considered as the pivotal person in bringing about this concept. And so today he is going to talk about this active surveillance in prostate cancer from bench to bedside. And in addition, he'll also talk about some of the landmark studies in prostate cancer. I would request Professor Laurence Klotz to deliver the oration online from Canada.
Thank you. Thank you very much for that kind introduction. I am aware of the high esteem that Professor Sarinder Mansingh is held in India, and it is really a great honor and privilege to be selected to give this oration. This is my home city of Toronto. It's a beautiful city. It's a very multicultural city. As you probably are aware, there is a huge population of people from India and Indian heritage in Toronto, and I really would encourage you to visit, and if you do so, to please get in touch with me. My disclosures: I've received research support from Exact Imaging, and I'm a consultant to Mir Scientific. I'm going to briefly mention both of their products in the talk. So I thought I'd begin with a little bit of a historical overview of this whole concept of active surveillance. So this goes back now 25 years to a lunch meeting that I had with two of my close radiation colleagues, Richard Chu and Cyril Danjou. And I think in retrospect, it's no accident that this came out of a multidisciplinary interaction between myself as a urologist and my radiation oncology colleagues, because we both had come to the conclusion that overtreatment of low-grade prostate cancer was a problem. And the context here, I was about 10 years out of my fellowship, and I had really imbued from my mentor, Dr. Willett Whitmore, the chief at Sloan Kettering, this idea of the primacy of tumor biology in outcome. And his aphorism, he had many, but the most famous Whitmore aphorism is cure possible when it's necessary, and is it necessary when it's possible? Meaning the patients you cure are the patients who perhaps don't need a cure, and the patients you are unable to cure are the ones who really have life-threatening disease. And there were also studies by a number of colleagues of mine, somewhat older than me, Nicholas George, who's not well known at all, Jerry Chodak, who died prematurely a few years ago, and Peter Albertson, who had all come out with studies suggesting that low-grade prostate cancer had a relatively low mortality rate when it was treated conservatively. But there were really only two options in those days. Either you treat radically or you don't treat at all. And we reasoned that many newly diagnosed patients presented with a low PSA or mildly elevated. The biopsy showed low-grade cancer, whereas the ones we were seeing with life-threatening disease had a high PSA, had a higher grade cancer, and maybe there was a transition period. And that if we tracked them and identified the patients in transition, either because of a rapid PSA rise or upgrading on repeat biopsy, that by intervening in a delayed fashion, we could still cure them and avoid treatment in the majority. This did not seem like rocket science at the time, but I can assure you that none of us had any idea that this would have the kind of impact that it eventually had. We decided to set up a prospective cohort. We had a new prostate cancer research foundation, the PCRF in Canada. This was their first grants competition. I applied. We won the grant, $35,000, which allowed us to set up a database, hire a data manager, and we started collecting information on these patients. And the climate then was quite different. So nerve-sparing radical prostatectomy had been described in the late 80s, early 90s. There was huge enthusiasm for this. This was, of course, pre-robot, but this was considered a panacea. And Pat Walsh, the father of the radical prostatectomy, argued strongly that the ideal patients were ones who would have negative margins. He believed if you had a positive margin, your operation was not useful, and that these, therefore, were Gleason 6 patients should be selected for this. At the time, we know from large data sets like Capture that 95% of low-risk prostate cancer in the United States, Canada, and to some degree in Europe was treated radically, 95%. So we started managing these patients using this approach. And our first publication was in 2002. We had about 250 patients. There were no deaths. And this really launched a firestorm of reaction. And people said this was unethical. People said that patients will die unnecessary deaths from prostate cancer, and you, Dr. Klotz, will be responsible for their deaths. And the skeptics also said, well, even if you have a point, you're never going to convince American physicians, whether surgeons or radiation oncologists, to stop treating patients radically. So there was definitely a lot of opposition to this initially. And now here we are 20 years later, and a lot has changed. So first of all, initially, there was not really a consensus that overtreatment was a problem. I would say no one disputes that today. The controversy today is not over the principle, it's over the application, exactly who is a candidate, how should they be followed, and so on. We know much more about the failures, that a significant proportion of these grade group 1 patients harbor occult high-grade disease, and that is the Achilles heel of this strategy. We know more about the predictive value of baseline parameters. We can identify the patients at risk of having clinically significant cancer that's missed on the biopsy using widely available parameters. I'll come back to that. We relied on PSA kinetics for the first 12 years or so. We treated patients whose PSA rose rapidly. We now know that is not correct, that you will overtreat a lot of patients because it's very common over time for patients to have a transient spike in PSA. It's not reliable. Of course, today we have the additional tools of multiparametric MRI. We're doing targeted biopsies. There's a lower rate of reclassification because we find the occult higher grade cancer early on with the targeted biopsy. We have a lot of modeling based in large part on the large prospective cohorts that are pre-MRI, but these show that even if the mortality rate gradually creeps up over time, the approach is very robust. We have also mature large registries totaling more than 15,000 patients being followed prospectively. And this is important because the criticism for many years was, you're just reporting too soon. If you follow these patients long enough, they will start to fall over a cliff of prostate cancer mortality. And that has simply not happened. There are now many, many hundreds of patients who've been followed for 15 to 20 years, and we just have not seen that increase in mortality. And finally, the whole area has taken off scientifically with more than 4,000 publications based on a Google search of active surveillance in prostate cancer. And this is now reflected in guidelines. This is a surveillance aircraft. Active surveillance is now the standard of care for just about every national or regional group that has guidelines, NCCN, AUA, Canada, EAU, Japan, Australia, and so on. But the field remains extremely active. And this is just a summary of progress in the last couple of years, I would say 5 years. We know much more about the molecular genetics of grade group 1 cancer compared to higher grade cancer. I will come back to that. The main point is that 90% of grade group 1 cancers have essentially normal molecular genetics, not 100, but the vast majority. We know more about how to select patients, the impact of things like age, which is associated with higher risk and higher grade cancer, and race. We know about the value of germline testing, particularly identifying patients with HRR or DNA repair defect mutations that make them poor candidates for surveillance. We have data on MRI and novel modalities like microultrasound, PSMA, the emerging field of radiogenomics to predict genetic aberrations based on the pixelated abnormalities on the MRI. We have a profusion of biomarkers. We know more about the limitations and the value of existing ones and the promise of new ones. I'll come back to this. We have predictive nomograms that enable us to use clinical parameters to predict who is at risk for high-grade cancer. We have the modeling that I mentioned, long-term outcome, better information on what is optimal follow-up strategies. There's been some fascinating data recently on the influence of the tumor microenvironment, the impact, for example, of obesity. I'll come back to that as well. We have information on the lack of value of dietary modification, but there are other innocuous interventions that look very promising to improve not only the risk of prostate cancer mortality, but the patient's general health. And finally, I guess this is the sign of a field that has reached some maturity as you start getting a profusion of systematic reviews, meta-analyses that address current controversies. I'll show some of those. So I'll just begin with a few comments about what we have learned about the molecular genetics of grade group 1 prostate cancer. So this is one of a number of papers, but I think it's a very illustrative one. And this paper from UCSF calculated the average genomic risk, which is also a term for a meta-score of genetic aberrancy and aggressivity. In other words, what is the cumulative, the total genetic alteration burden for each prostate cancer case? And this is a heat map. And the second line here is the Gleason score. Light blue is low grade, dark blue is high grade. And you can see as you go from left to right in the heat map, these cases tend to become darker blue or higher grade, but it's not absolutely black and white or light and dark. There are some light colored cases out in the high genetic aberrancy quartile here. And the metrics are that 2% of grade group 1 are in this highest quartile. So that's not zero. But I think what's going on with these cases is they are in transition. In general, genetic alterations precede histologic changes. And if you were to rebiopsy these patients in the near future, they would likely have transitioned to higher grade. As soon as you have any element of Gleason 4 pattern, so grade group 2, 7 times higher rate of genetic aberrancy, of adverse genetic aberrancy. So most grade group 1 are favorable, a very small proportion are unfavorable. And I mentioned this idea of grade progression. So there are two phenomena at work when you have a patient diagnosed with grade group 1 cancer. The first one is misattribution of grade, and we know that is very common, that with systematic biopsies, it's about 30%. With targeted biopsies as well, it drops to about 15%. But somewhere between 15 and 30% of patients diagnosed with grade group 1 cancer will harbor higher grade cancer, usually grade group 2, but occasionally even higher. So that's a real issue early on. And that is why early on, we now believe imaging should be mandated and at least one confirmatory biopsy. But then in the majority of these patients, you satisfy yourself that you've identified the occult cancer based on imaging and repeat biopsy. And then the issue becomes true grade progression, where you have usually a large field of grade group 1 that transforms into high-grade cancer. Biology, after all, is dynamic. And the question is, how often does that occur? And there are 3 groups that have tackled this, including ours, based on serial biopsy over time. And all groups have come up with the same figure of somewhere around 1 to 2% per year. So in the short term, this is not really an issue. Because you are following these patients long-term over a period of 10 or 15 years, it starts to become more significant, say 10 to 15% risk of true grade progression at 10 years. Most of those have progressed to Gleason 3+4. It still may not be a life-threatening cancer if you have an older patient, but this is something to be aware of. In the short term, misattribution. In the long term, true grade progression. And there's been some major progress in this area of genetic predisposition very recently. And this is led by Bill Catalona from Chicago. And this is ironic to me because Dr. Catalona was the single most vocal opponent of active surveillance for about 15 years. And of course, Dr. Catalona is a giant in our field and was the first to report in the New England Journal the use of PSA as a screening test for prostate cancer. And he truly believed that these patients should be treated radically. But to his credit, he changed his mind after many years. He now leads this SPORE, or this large research group, studying genetic polymorphisms in men on active surveillance, how to predict from germline alterations who is at risk for progression. And they just reported this a few months ago, a huge initiative, almost 6,000 patients who were subject to genome-wide genomic analysis and identified 18 polymorphisms associated with conversion to higher grade cancer. And amazingly, 15 of these had not previously been associated with prostate cancer. We're just at the beginning of this research program to understand what these 15 other genes are. Are they functional? What is their significance? And they developed this risk score based on 269 variants that really stratifies patients very well according to their risk of progression to higher grade cancer. So stay tuned, there'll be more coming, but this just shows the great potential of genomic analysis in improving the management of these patients. So that leads to another issue, which is, can you include, for example, intermediate risk patients with grade group 2 or Gleason 3+4? And you can see that pretty much every group that develops guidelines says, make some comment like may be offered to select patients, may be considered, can be considered, etc. So there's a potential role. The question is, how do you pick these patients? Just to emphasize the natural history of grade group 2 versus 1. So with grade group 1, you can say to the patient with, I think, very, very high confidence that grade group 1 cancer is non-metastasizing. The cancer that they have been diagnosed with, or the so-called cancer, poses zero threat to their life. What does pose a threat to their life is either the presence of higher grade cancer that you don't know about or progression to higher grade cancer, but it is still often quite favorable. So this was a recent study from the US that looked at long-term mortality in patients followed with surveillance who were intermediate risk. And there were more than 1,000 patients with intermediate risk disease, 3/4 of them grade group 2, 1/4 grade group 3. And the mortality at 10 years was 3.7% in the grade group 2, 12% in the grade group 3. So we also have data on this from our series. Our 15-year metastasis rate was actually considerably higher. It was more like 30%, but that was kind of an older series. So this just shows you that while men with intermediate risk cancer are more at risk from metastasis, the risk is still relatively low. The 1.1% in the low-grade group, Gleason grade group 1, is not zero. And that is not the grade group 1 that's metastasizing. This was based on biopsy. These patients harbor higher grade cancer, and occasionally they will progress. So that's consistent with other series. This is some data we published recently on the importance of compliance with follow-up. So there's very little evidence in the whole oncology field that actually how you follow patients after diagnosis really makes a difference. We looked at how patients did in our cohort, whether they came back for follow-up, and particularly whether they had the confirmatory biopsy. And it turns out, somewhat to our surprise, this did make a difference. So whether it was recurrence-free survival, metastasis-free survival, cause-specific survival, the patients who complied with the follow-up program, underwent the follow-up biopsies, had improved outcome in terms of prostate cancer mortality compared to those who did not. So it just emphasizes the importance of follow-up in these patients. One other recent study that I think is reassuring about the intermediate risk patients from UCSF compared patients who were upgraded and were treated right away to patients who were upgraded, remained untreated, and underwent a late operation. Maybe they were wedded to the idea of surveillance. They wanted to think about it for a while. Maybe they were reluctant to have surgery, understandable. No difference between these two groups, whether they had early or delayed intervention. And so I think the message is this is not an emergency. Grade group 2 can be managed conservatively, certainly for a while, without adversely affecting the outcome. Now, the next point is about patient selection. So first, I mentioned the nomograms earlier. This is the latest one from the Canary collaboration, which is a collaboration of academic centers on the West Coast of North America. And this is a very powerful tool that uses no fancy parameters: age, BMI, PSA, prostate volume, time since diagnosis, and the maximum core ratio. How many cores were positive out of the total number of biopsies? And this gives a very tight prediction of the likelihood of upgrading at the next biopsy. And this is just a typical example. So you don't need to do the genomic assays. You don't need expensive tests to have a very good predictor for the likelihood of upgrading. And this is freely available on the web, and I'd encourage you to use this. Of course, the next major advance has been the use of MRI, which is a phenomenal tool and has really changed the game. But it is not perfect. It has important limitations. It's not real time, so the patient has the MRI, then typically has to come back another time for the biopsy. It requires special training. There's artifacts induced by treatment and biopsy. It misses lesions, and I'll come back to that. This is probably the most important limitation, is that it will miss particularly small but high-grade lesions. There's cost, complexity, issues of access, claustrophobia. Pacemakers preclude the test in some patients. Insurance coverage is often a barrier. We have issues in Canada with access to MRI. I am sure that you have that issue in India as well for the vast majority of patients who don't have private insurance. And finally, even if you overcome those issues, it can lead you astray. So this is 3 examples of where MRI has been correlated with biopsy over a 3-year period. The top one is everything is stable, MRI is stable, biopsy shows nothing further. The second one is the important example of grade and MRI progression. So you have a small lesion on the left, 3 years later, it's about twice the size, and the biopsy shows grade progression. So far, everything is beautiful. But here is the problem. You have a stable MRI, but you have grade progression on biopsy. And this turns out to be all too common. This is one series that emphasizes this. There are several now. This was more than 200 men at Memorial Sloan Kettering who had a serial MRI and biopsy at 3 years. About a third of the men whose MRI was completely stable were nonetheless upgraded to grade group 2 or higher on the biopsy. And that is disconcerting. And there were even about 20% of men whose MRI improved and the biopsy showed grade progression. So MRI is helpful, but you can't rely on it. And just one piece of clinical evidence to again support this observation. This also comes from the Canary collaboration, men with grade group 1 on surveillance. The MRI the target biopsy did not increase the rate of upgrading in these series. And the message was, you still need the systematic biopsy, even if the MRI is negative. The reason for this is that the sensitivity is only moderate. So this is a recent systematic analysis of all of these MRI studies in men on surveillance, sensitivity 60%. So that's a big gaping hole of 40% false negative MRI with grade progression. Specificity is somewhat better. So this leads me to the next topic, which is, I think, some of the recent developments that can help. And I am a big fan of this novel imaging tool called high-resolution microultrasound. So the difference here is that conventional ultrasound is 6 to 9 megahertz, which gives a resolution of 200 microns, 0.2 of a millimeter. 29 megahertz, higher frequency, higher resolution, the resolution is 70 microns. That is the diameter of a prostatic duct. And what it means is that alterations in ductal anatomy, which is exactly the same principle that results in restricted diffusion and an MRI signal with higher grade cancer, can be seen with this imaging technology. It looks and costs kind of much like a conventional ultrasound, high-end ultrasound, I would say, but it's commercially available. It's a short learning curve for people who are used to doing ultrasound. And this is a study I published a year or so ago, comparing in the first 11 sites around the world to start using this technology, how did it perform compared to MRI? And this is not a perfect study, so it reflects the learning curve at these sites. But even so, you can see here the sensitivity of ultrasound was actually as good, in fact, a little better than MRI for finding significant cancer. The specificity was about the same. There's now some better studies coming out where there was systematic blinding to the MRI, which we didn't have in the registry that I just showed. So this one is from Milan, Italy, and compares MRI to ultrasound. The ultrasound is the Primus score, MRI is PIRADS, and you can see for each score, the positive predictive value for clinically significant cancer is almost identical. These are complementary. There's about 10 to 15% of cases that are positive on MRI, negative on ultrasound, and vice versa. But I think the appeal of ultrasound, this new technology, is that, first of all, urologists use it. So you kind of recapture imaging back into urology practice. Second, it's dramatically less expensive and potentially more accessible. It's basically just an ultrasound unit, doesn't require a dedicated technician and so on. So for MRI resource-constrained healthcare systems, which I would include Canada and many other regions of the world, this is really appealing. And in my practice, I use it in conjunction with MRI, but it has certainly replaced a lot of the MRIs that I would have done otherwise. The next area is biomarkers. So there's at least 9 commercially available biomarkers. They test blood, urine, and tissue. They're all trying to take the patient who's been diagnosed either with a negative biopsy or with low-grade prostate cancer. What is the risk of this patient harboring aggressive disease? You can see the area under the curve varies from about 0.75 to 0.90. The one with the highest area under the curve is the Select MDX urine-based assay, but none of these have been compared head-to-head, and therefore you have to look at these comparative areas under the curve somewhat with somewhat of a grain of salt. They all work to a degree. The cost varies a lot. The liquid biopsies are mostly around $500. The tissue-based genetic assays like Oncotype DX and Prolaris are around $4,000 to $5,000 US. This is a big chunk of change. They are very labor intensive. They require microdissection of the cancer cells and so on. Just to focus on the tissue-based one, these do have value. You can see that they either identify the risk of disease progression or the probability of metastasis in the case of the Decipher one. But here's the problem. The problem is tumor heterogeneity. And this is one of a number of studies that have addressed this, and I think pose a challenge to the tissue-based assays. You have a patient who's had a biopsy that shows grade group 1, and you send the tissue off to Genomic Health or Myriad for the genetic assay, and they tell you what the molecular genetics of those cancer cells are, but is that telling you what's going on in the rest of the prostate? And the short answer is not very well. So this study looked at the issue of the genetic heterogeneity in different cancers in the same prostate. 41 patients, each of whom had about 4 different cancers. So these were micro-dissected and subjected to whole exome sequencing. And the take-home message is about 95% of the genetic alterations in these cancers were, the gray you see here, unique. They were not shared. About 5% were common to all the different cancers. So you get a genetic readout from your grade group 1. It doesn't mean that it's telling you what is going on in the other cancers in that prostate that you don't know about. And this is a study from, again, the Canary Pass group that looked at the additional value of Oncotype DX. And remarkably, it did not really contribute. Adding the GPS assay to PSA density and the grade group did not improve stratification for adverse pathology. You see the curves here. Now, these assays do work. They do tell you, they do identify patients who are at increased risk for adverse pathology. But in the average patient with grade group 1 on surveillance, in my view, they don't have a role. They're too expensive and they're not reliable enough. That leads to the liquid biomarkers. And I'll just briefly mention this one, which I'm quite involved with, the Sentinel Assay. This has been developed over the last 5 years or so. It's based on urinary exosome small non-coding RNAs. The difference between this one and the others is, whereas, for example, the Oncotype DX is based on about 30 genes, the Exosome DX assay is also a urinary microRNA assay that examines, I believe, 4 genes sequences. This one interrogates 442 microRNA sequences. These microRNAs are small non-coding RNAs. They have regulatory function. There are about 9,000 of these have been described. The 442 most predictive have been picked out. And you can see here the predictive value of this assay. This is on the left, the presence or absence of cancer. On the right, clinically significant cancer with areas under the curve of 0.96 to 0.97. Really very powerful predictive value. And this assay is being developed to be, we hope, available worldwide at a modest cost. So stay tuned for more about this. And this will lead, I think, once we have these accurate, widely available, not too expensive assays, to what's called a continuous individualized risk index or dynamic risk profiling over time. Imagine you have a patient with grade group 1 disease. They have one of these assays, it's negative, you repeat it on an annual basis, and suddenly it converts to positive. And you have data that is a reliable indicator that the patient has had grade progression. And this will allow you to reduce the biopsies dramatically, allow you to reduce the amount of imaging. And I think that's the future of this field. We're not quite there yet, but we're going to be there in the near future. Finally, innocuous interventions to improve health and perhaps reduce the risk of disease progression. So first, these are what I call the motherhood recommendations. Stop smoking. When you have a patient who's been diagnosed with cancer, they are very susceptible to messages about their health. And we have data that as a specialist, if you spend 2 minutes counseling a patient who smokes to stop smoking, that you can alter significantly their smoking behavior. That is the single most cost-effective intervention in all of medical practice, which is saying something. And so I really encourage you to take on smoking cessation. Just mention it to the patient, tell them how important this is. You'll be doing them a huge favor, probably more benefit to their health than whatever you do with their prostate cancer. Dietary modification. Again, everyone knows this. Reduce obesity, moderate red meat intake, increase fruits and vegetables, and regular exercise. If exercise were a drug, we would all take it. This is one review article. There's 8 different pathways by which exercise has been found to alter the tumor microenvironment: epigenetic modulation, hormone levels, cytokine levels, immune function, and so on. Now, interestingly, a very recent randomized study of the impact of high-intensity interval training in men on active surveillance was published. This was kind of a pilot study, 52 men, so 26 men in each group. One group got exercise trainer, and I believe 3 or 4 times a week was put through this high-intensity exercise versus usual care. And for the first time, there was actually some evidence of an impact on prostate cancer. So PSA kinetics improved, doubling time improved, and PSA went down. There was also an improvement in the general health of these patients: cardiovascular fitness, anxiety, and fatigue. This, I think, is well known, but it just shows that actually this is not just hypothesis or preclinical data. There's actually some evidence of a benefit in prostate cancer. Let me keep going. The other, really, I think this was a fascinating article. If any of you are interested, in New England Journal last year, the effect of obesity and the tumor immune environment. So it's well known that obesity and prostate cancer are not a good combination. Obese men tend to have higher mortality, present at a more advanced stage of prostate cancer. We never knew why. And this article addresses the mechanism. And the mechanism is that obesity induces a metabolic tug of war between the tumor cells and the immune cells, particularly the T cells in the tumor. And somewhat paradoxically, in the face of obesity, the tumor cells increase their fat uptake, which is depriving the T cells of necessary fatty acid substrate. And this results in impaired T cell function and reduced immunity and the risk of tumor progression. And there's been some mechanistic studies also published that have linked this to a pathway called prolyl hydroxylase 3. But the message is that obesity impairs tumor immunity by essentially starving the immunocytes of needed fatty acid substrate. So obesity is certainly best avoided, and ideally in patients who are obese, they should be counseled to try and improve this. And this is one clinical study showing evidence of this in prostate cancer, that the periprostatic fat volume is associated with an increased rate of grade progression. So just emphasizing this idea that the fat may be adversely affecting tumor progression. And one more study showing that increased BMI is a risk factor for poor clinical outcomes after surgery. Again, not really a surprise, but just emphasizing the message. So if you can get your obese patients to lose weight, you're doing them a favor at multiple levels. What about dietary modification? This was probably the best data we're going to have on this, just published a year or two ago. Almost 500 men on surveillance randomized between aggressive intervention towards a vegetarian diet. Now, this may be less of a problem in India, where I think meat consumption is much lower than in the West. But this, of course, was a Western study, dietary modification to a vegetarian diet versus a pamphlet. What was the impact? The impact was non-existent. It was a completely negative study. So no difference in PSA levels, PSA kinetics, or upgrading on follow-up biopsy. And I think the message here is, it's not that diet isn't important. Every doctor knows that the diet over a lifetime has a huge impact on health. I think what it does say is once the patient is diagnosed with prostate cancer, at least in the intermediate term, it doesn't make much difference. So, I advise patients eat a healthy diet, but don't go overboard. They don't have to dramatically alter their diet just because they've been diagnosed with prostate cancer. And then the final series of points are on, I see a lot of men who say, look, I understand what you're saying, but I'm not happy with the passive aspect of this. I want to do something. Is there anything I can do to prevent this disease from progressing? So there's 3 things that I recommend, none of them supported by prospective randomized trials yet, although some of these studies are now being done. It's vitamin D, and this particularly in northern countries like Canada, maybe less of an issue in India, but vitamin D deficiency is very common in the elderly in my country. Low-dose statins and metformin. I'll just show briefly some data about this. There's a lot of data that low levels of vitamin D this is a systematic review. Low levels of vitamin D are associated with an increased risk of prostate cancer. Every single study that's looked at this has shown this relationship. Vitamin D costs about 3 cents a day. It's harmless at the dose of 1,000 to 1,500 units. We don't have proof from a randomized trial, but I tend to encourage my patients to go on vitamin D supplements. Statins, and this is a long story, but there are many studies, again, another systematic review, showing that men on statins, I believe that the statins are a prostate cancer drug. They also have some benefit in men on ADT. But in the surveillance setting, there's a lot of data that men on statins have a lower rate of prostate cancer mortality, metastasis, and this has other cardiovascular benefits in terms of improving lipid profile. So I encourage all these patients to be on at least a low dose of statin, like atorvastatin, 10 milligrams. And finally, metformin, the diabetes drug. Metformin increasingly is looking like a health promotion drug. Non-diabetics who go on metformin have essentially no side effects. They do lose some weight, and there's 2 mechanisms, both a direct and indirect mechanism, by which metformin appears to inhibit cell growth in men with prostate cancer through the mTOR pathway and through the direct mechanism of reducing energy expenditure and free oxygen radicals in prostate cancer cells. And this is one systematic review of this, 30 cohort studies, 1.6 million patients, metformin versus no metformin. Again, these are registry studies. It's not randomized. We actually are doing a randomized study now in men on surveillance, metformin versus placebo. But you can see here from the registry studies, pretty dramatic evidence of a reduced prostate cancer. This is recurrence-free survival, cause-specific survival, all improved with metformin, mainly, of course, in diabetics on metformin compared to those who are not. So this is, again, pushing the envelope a bit, but I think given how innocuous, inexpensive these drugs are, it makes sense. So our current management protocol, 12-core biopsy plus or minus targeted, MRI within the first year if it wasn't done previously. Increasingly, this is being replaced by high-resolution micro-ultrasound, where in those centers that have it. PSA every 6 months. DRE, we do it, but don't really put much stock in it. Confirmatory biopsy within the first 1 to 3 years. So this is really important still, but it doesn't have to be done right away. There's some modeling that suggests you can wait. Repeat the MRI every 2 to 3 years. Targeted biopsy if there's a change. Based on the data I've shown, we have not abandoned periodic biopsies, but only do it about every 5 years if the other parameters like the MRI and PSA are stable. The only reason to intervene is grade progression. Seeing volume progression on biopsy is, if it's still grade group 1, it's non-metastasizing, you don't have to treat those patients. So the take-home message, this has become the standard of care worldwide. This is a non-metastasizing cancer. You don't have to worry about higher volume Gleason 3 metastasizing. It does not do that. You do have to undertake the challenge of finding the occult coexistent higher grade disease with a repeat biopsy and imaging and monitor for late progression. There's still an increased rate of adoption going on. In Canada, it's about 90% of eligible patients. In the US, it's about 50 to 60%. I'd be interested in the metrics in India. I don't know what they are. We think that imaging before biopsy and not biopsying patients with negative image will reduce the finding of grade group 1 cancer, but it's not going to go away completely. It's reduced from about 25 to 30% to about 15%. These imaging modalities are game changers, and I think now the challenge is to broaden the indication to selected patients with grade group 2 where they have favorable molecular markers. Now, I'm just going to wrap up, briefly summarize landmark papers in prostate cancer. And this second part of the talk could easily take me half an hour. I'm going to go through it extremely rapidly, but I've selected papers that I think are foundational, that inform daily practice, but that people may not be aware of because they've slipped into the background. So obviously there's many choices here, but this is my particular one. So first of all, Gleason Score. So you can see here, published 1974 by Donald Gleason, prediction of prognosis for prostate cancer by combined histologic grading and clinical staging. This is definitely old style publication, but you can see here histologic pattern in relation to the risk of prostate cancer. There's no Kaplan-Meier curves here, but this was really a landmark publication showing that the value of Gleason scoring system. And here it is almost 50 years later, it is still the best single predictor of natural history of prostate cancer. And the Gleason grades are shown down there. This is starting with grade group 1 up to 5. Of course, now we only really start with grade group 3. It's been modified several times. The next one, the description of PSA, 1979, by M.C. Wang and Jerry Murphy at Roswell Park. So obviously this was a fundamental observation. The interesting thing about this paper is Dr. Wang was a postdoctoral fellow in Jerry Murphy's lab, and his career did not pan out. He left science. And it turns out that about 20 years later, when PSA was the rage, he was selling real estate and had no idea that this discovery of PSA had the kind of amazing, profound impact that it did. So it's unfortunate for him that his scientific career didn't pan out, but I think that's quite interesting. I mentioned Bill Catalona at the University of Chicago, the first paper, New England Journal, 1991, describing the value of PSA as a screening test for prostate cancer. So it's just interesting. It took about 12 years to go from first description to the first study actually showing that this was useful as a screening test. And basically you can see at the bottom here, the higher the PSA, 4 to 10 and 10 and higher, the greater the risk of prostate cancer. Now, of course, excuse me, The massive hole in this data is that there was no negative controls who had a biopsy. And it wasn't until the PCPT trial about 15 years later that we learned that actually men who had normal or low PSA also were at risk for prostate cancer. And that kind of undermined the value of the test for quite a while. Then we had these screening studies. These, of course, are better known. The ERSPC, published by Fritz Schroeder, the first publication in New England Journal 2009, showing about a 20% risk reduction of prostate cancer mortality. And then the subsequent publication 3 years later with 11 years of follow-up, now showing a more robust improvement in prostate cancer mortality. So this is really the basis for PSA screening, still very controversial. And then the other, I would say, pivotal but negative trial was PLCO. ERSPC was 182,000 men, you see there. Absolutely staggering achievement. PLCO, 72,000, completely negative. Somewhat more cases diagnosed, but mortality here, no difference. Why is that? This is now known. It's due to contamination. 85% in the men in the control arm had at least one PSA. 15% in the men in the study arm were non-compliant, didn't have a PSA. So in other words, the same proportion of patients in both arms had at least one PSA. More PSAs in the study arm, which accounted for the greater case finding. But that's why this was a negative study. The problem is many groups that look at screening, look at these two studies, they say one's positive, one's negative. I guess overall it's a wash, and that is not a correct interpretation. Screening has value. I mentioned a couple of these studies of natural history of prostate cancer. This one's not well known at all. Nick George at University of Manchester. For the first time, this is published in 1988. I remember seeing this paper when it first came out. I was just newly in practice. And what he showed is basically with conservative management, conservative therapy alone, a relatively low mortality rate, somewhere around 15% at 7 years. And this was really the first time that this observation had been made that actually the majority of patients were not at risk of dying if you didn't treat them. This then led to the SPCG4 by Holmberg, published in 2002, radical prostatectomy versus no treatment, that showed about a 50% reduction in prostate cancer mortality. Every time anyone in the world does a radical prostatectomy, it is leveraging the information from this really pivotal trial that showed a reduction in prostate cancer mortality with surgery compared to no treatment. This is somewhat of a historic cohort. It was PSA came in during the middle of this trial. So a lot of the patients were actually diagnosed based on DRE or after a TERP. And this study, of course, has now published several times. This is the fourth publication in the New England Journal of the same cohort, now 29-year follow-up. And it reinforces the value of surgery compared to no treatment for higher grade cancer. But there's one other very critically important message from this study that's relevant to my talk. And you see it down here. This is the hazard ratio, the relative risk of for each grade, now with 29 years of follow-up. So for the higher grade cancers, the mortality risk reduction is 5 to 10-fold, huge impact. But Gleason 3+4 in this foundational study, no evidence of a benefit, hazard ratio 0.99 for no treatment compared to surgery. So this doesn't mean grade group 2 patients don't benefit from treatment. They do, but not that much. And so this is, of course, the role for active surveillance for selected patients. I included one paper by myself. This is one of the first two papers on expectant management. We didn't know what to call it then. Expectant management, selective delayed intervention. I actually came up with the term active surveillance after this was published, and that obviously caught on. So but this describes the first 200 patients, Gleason 6 cancers, no deaths, 8% grade progression, and this was kind of had a real impact. And then the other paper comparing surgery to no treatment, again, this was not active surveillance, it was no treatment in the control arm, was the PIVOT study. This was an older, sicker VA population. This essentially showed little or no benefit of surgery. It's still a controversial study, but again, reemphasizes the point that the patient's overall health and comorbidity must be taken into account in deciding whether to treat them radically. A natural history study called the Pound study. We refer to that. I ask my residents about this all the time. It should be better known. This was a group of patients of Pat Walsh's, about 2,000 patients who were treated with surgery, and Dr. Walsh did not believe in adjuvant therapy. So the strength of this study is the patients got no additional treatment until they metastasized, and this will never be repeated because now we intervene. But the key point is the mean time from surgery to PSA rise, 3 years, from PSA rise to metastasis, 8 years, from metastasis to death, another 5 years. So that means the median time in the 18%, so less than 20% actually died of prostate cancer, but in those patients, the median time to death, these are the worst patients, 16 years. So it is a long-term disease, and even in the ones destined to die after surgery, it takes a heck of a long time, 16 years. Everyone who treats prostate cancer should have that number in their mind, and it's based on this series. This was from Stephen Friedland, showing the relationship between PSA doubling time and other parameters and prostate cancer mortality. And the key point you see down here on the left, the 15-year estimates of prostate cancer survival vary from 94% in the patients who have a doubling time of more than 15 months, who take more than 3 years to recur, and who have lower grade cancer, to almost zero in the patients at the other end of the spectrum. So you can very much risk stratify these patients. I'm thinking in the interest of time, I'm going to skip through a bit of this. I think this is the focal therapy. This is the classic paper by Ahmed and Emberton showing the trifecta of continence, erectile function preservation, and no recurrence of about 85% with focal therapy compared to, this compares very favorably in terms of the trifecta rate with surgery. So this has led to huge interest in focal therapy, now hundreds of papers, still a very intense debate about the role of this. And then the final group of papers, and I know I'm a little over time, the final group of papers are the whole hormone therapy story. This study led to a Nobel Prize for Andrew Schally, structure of LHRH. And the historic point about this study, it was an amazing case because he isolated this from pig hypothalamus, where it was present in infinitesimally small amounts. So he personally had to harvest something like 5,000 pig hypothalamuses to extract 200 nanomolars of material to purify it. And here's the conclusion: only one structure, the decapeptide structure of LHRH, was consistent with the data. So we owe him a real debt. And now there's all kinds of issues around ADT still. 2 intermittent studies that I think are very important. This is the Canadian study showing no difference in men with PSA failure between 8 months of induction versus lifelong hormone therapy, and the SWOG 9346 study by Mahak Hussain showing essentially statistically inconclusive. Could not prove non-inferiority or superiority or anything else. So I believe intermittent therapy still has a role, although it's had less attention recently. And finally, the role of adjuvant hormonal therapy. So this is the famous BOLA trial showing the benefit of 3 years of adjuvant ADT in men receiving radiation. We've now moved a long way beyond this, but it's still adjuvant ADT after radiation is increasingly a standard of care. So thank you very much for your attention. I hope you found that interesting. And again, thanks for the honor and the privilege of giving this talk.
Thank you, Professor Klotz. We have been very lucky to listen to Professor Klotz, who is the originator of the concept of active surveillance in prostate cancer. And his talk on prostate cancer was obviously very illuminating. Regarding, you had asked us one or two questions. One was regarding the Indian situation of active surveillance. In all the academic centers in India, like All India Institute and PGI Chandigarh and SGPGI, we are following this principle of active surveillance, but how much it is being followed in the private practice setup in India is something about which I cannot comment. And you talked about vitamin D deficiency. Vitamin D deficiency in India is also a major problem, despite the fact that we have a lot of sunshine, but practically most of us wear, full sleeves shirts, and our exposure to sunlight is minimal. And we are having mainly a vegetarian diet, and therefore in the vegetarian diet vitamin D is less, and vitamin D deficiency is in fact a major problem in the Indian population. Regarding we also have we had a visit by Dr. Fritz Schroeder about, I think, 12, 13 years ago or 15 years ago to All India Institute. And before I open, as you had kindly agreed that you would welcome questions. So now I think is the time for questions, or if I would like to ask you a couple of questions. One is regarding, apart from the research setting, in grade group 1, what is your actual clinical practice in terms of genetic testing?
So that I didn't get a chance to cover that. That's a great question. And really what we're talking about is testing for, today at least, for BRCA2, BRCA1, and ATM mutations, other DNA repair defect mutations. So this is an evolving area, but we are moving towards the point where we're going to test everybody. We're not quite there yet. It's only about 4% of patients diagnosed with low-grade prostate cancer will have these, will have an alteration. So if the patient has any significant family history, particularly if anyone in his family has died of prostate cancer, they get tested. If they have a relative who's diagnosed at a young age, they get tested, and increasingly they get tested if they kind of express some interest. So the net, we are broadening the net. The test can be done by the patient with, for example, colored.com or Invitae. It costs only a few $100s. It's really a lot of value. And then the question is, if you find particularly a BRCA2 mutation, in my opinion, the patient should have surgery, because the impact of DNA repair is to accelerate the accumulation of mutations. And if you are planning long-term follow-up in a patient who's been diagnosed with cancer, that is not a strategy that makes sense. So that is the only group of patients with grade group 1 where I tell them I think you should have surgery. Why surgery over radiation? There is one paper on this topic from the UK that showed that men with BRCA2 mutations treated with radiation had virtually 100% mortality, whereas the ones treated with surgery had about the same mortality as the ones who didn't have the mutation. That hasn't been corroborated, but just because of that one data set, I really tend to push these guys towards surgery.
Are we talking about in
Well,
your population?
Yeah, that kind of depends on the context. You could say young means younger than I am, but which is increasingly more and more patients. But no, young means in prostate cancer kind of under the age of 60 to 65, I would say. The average age of diagnosis in Canada is around 68. I think it's similar in the United States.
So less than 65 or less than 60 you would take as young?
Yeah, yes.
Okay.
You know, part of the issue with family history, the impact of screening, you call it family history inflation. So you have a patient diagnosed with grade group 1, say 20 years ago, and because he was diagnosed and maybe he was treated, his family members are an increased likelihood of being screened because now they have a family history. And once you're being screened, you have an increased likelihood of being diagnosed with low-grade cancer. So you have to be careful of the inflation phenomenon in family history. But I think we're reaching the point where all that's going to become irrelevant. We're going to screen everyone because it's become so inexpensive and the implications are so significant.
And regarding this new technology of micro ultrasound, so what do you think is how many of these have actually been practically bought in Canada and
Yeah. So this is a Canadian invention. It's now available all over the world. I found out recently there's about 150 units so far around the world. The company is called Exact Imaging. They have a collaboration with EDAP, who make the focal therapy HIFU device. So it is emerging. The learning curve is short. It's a whole other talk about that. The learning curve is short for urologists who are familiar with ultrasound imaging. And yeah, I really think it's a real advance, and it's so much more accessible than once you have it. It's just like doing an ultrasound than MRI. And the performance seems to be very similar, so it's taking off.
so you think it is complementary or will it replace MRI?
I think it's largely complementary for a number of reasons. First of all, MRI does pick up lesions that can be missed on ultrasound and vice versa. Second of all, ultrasound is real time. So you're doing the ultrasound, you can store the images, but the tendency is to do the ultrasound, look at the images, and do the interpretation. Part of the appeal of that is you see a lesion, you biopsy it. So it's one stop. It's not 2 visits for the patient. MRI lends itself to kind of study and closer analysis. You're looking at all the different parameters. The radiologist can take some more time to analyze it more carefully. And there's also, it lends itself to artificial intelligence is an emerging technology with MRI. So I think they both have a role. In my practice, I alternate them. So I do each one about every 2 years now in the average surveillance patient.
Okay. Actually, I would have liked to ask you a lot of questions, and I'm sure there would be a lot of questions from other people also. But perhaps in the interest of time, we have to go ahead with your felicitation ceremony also. And I would request Madam Dr. Neena Khanna, our acting director, to felicitate you. So this is the plaque that you're going to receive. And
Wow,
for today, it's a picture. Yes. So I'm accepting it on your behalf, and it's my responsibility to hand it over to you. And
that's
this is
beautiful. Thank you.
So this is the certificate. Thank you, Professor Klotz. And now Dr. Sanjeev Lalwani, our registrar, he will propose a vote of thanks. वो उनको हाँ वो होगी बात
Good afternoon. First of all, I thank all the members of the Department of Urology for organizing this sixth Dr. Sarinder Mansingh Memorial Oration. And I take this opportunity to thank Dr. Laurence Klotz for accepting the request to deliver the sixth Dr. Sarinder Mansingh oration today with a wonderful talk. It was basically the talk which was very much relevant as far as prostate cancer is concerned. And I think everybody got enriched with your presentation. I thank all the members of the faculty who are present today, and thank Dean Academic to chair this occasion of 6th Dr. Sarinder Mansingh Memorial Oration. Thank you everyone for being with us today. Now I request you to join us for the cup of tea, please. Thank you.
We cannot invite you for coffee, and